Today we have Dr. Shailaja with us. She has completed her MBBS from MS Ramaiah Medical College, Bangalore, and diploma from Kasturba Medical College, Bangalore in Anesthesiology. Ma'am has almost 13 plus years of teaching experience in her field. She also has 10 plus publications on her name on various researches. She has vast knowledge on different fields as well: general medicine, emergency medicine, and trauma.
Welcome to the world of anesthesiology. I think COVID has brought in the anesthesiologists into the forefront. I have done my undergraduate from Ramaiah and postgraduate from KMC Manipal and from Hardamullas, Bangalore itself, where I've been working for the past 15 years. In anesthesia, I have a work experience of 13 years, and for the last 2 years, I'm heading the emergency medicine department in our college itself. Our topics for today would be: you would understand the importance of anesthesia in the undergraduate curriculum. And I'm sure all of you know that India has started adopting the competency-based curriculum since the 2019 batch. So you'll be able to understand what are the competencies that an undergraduate should know for entering into Indian practice. I'll just briefly tell about some of the books that is subject specific to anesthesia and some of the benefits of you people undergoing this Moksh online sessions. And I hope you understand that every teacher would have their own teaching methodology. I'll just brief you about how I would be going about with teaching this subject, and one slide about what's the weightage for this subject in the present NMC curriculum. Yeah, it deals with perioperative care. Perioperative care includes the preoperative assessment, preparation of the patient, intraoperative management, and the postoperative care. Perioperative includes preoperative, intraoperative, and the postoperative care and rehabilitation of the patient. Anesthesiologists also are involved in resuscitation, airway management, pain and palliative care, and also critical care. So it's one of the prime branches required, although not very well recognized, but it is an important field. We also deal with basic airway management skills. We also act as pharmacologists, physicians, intraop physician. We need to know a lot about drugs, drug mechanism, their pharmacokinetics, and we also need to document. Important part is how you are going to document either intraoperative, preoperative, or your resuscitations, and we are involved in performing a few procedures. We will be learning more about this as we go through our session on history of anesthesia and how anesthesia has evolved in the next session. Coming to competency-based undergraduate curriculum, it has started from 2019 batch, as I already mentioned earlier. The main focus is on how competent this Indian medical graduate is when he attends a patient in a health center, and he has to be involved in the care of this patient. So it is more of hands-on oriented, that is skills oriented. Whether you have attained the skill of taking history, physical examination, then the basic few skills that an undergraduate needs to know. There's more of focus to clinical exposure. So from the first year, they are entering the clinics as their early clinical exposure posting. It's more learner-centered, patient-centered, and it's an outcome-based curriculum. When I'm telling outcome-based, when you attain certain points, it is documented in the logbook, and there are certifiable skills. Each subject have got their certifiable skills. However, anesthesia does not have any certifiable skills at present. It doesn't mean that it will not be included in the assessment for exit exams. It is going to be assessed because it's an important part in the resuscitation. There is focus on integrating subjects and organ system based understanding. It is not a silo approach where you read anatomy separately, biochemistry separately, or physiology separately. focus is given on integrating, that is horizontal integration. They see that when GI system is covered in biochemistry, the same GI system is covered in anatomy, and the physiology is dealing with the GI physiology. So everything goes hand in hand. It may be weekly. There's also much importance given to the clinical relevance of these basic sciences, how it is clinically relevant. 2019 batch, when they had their first year paper, it was more of case scenario based questions even for their theory exam. Leave alone practicals. Practicals, they are planning on implementing OSCE stations. So it's more of how the basic sciences will be incorporated into the clinical part. That's the emphasis in CBME. And it's trying to replace rote memory learning with concept-based knowledge acquisition. The focus is becoming on good doctors. It's not about becoming great exam writers. We all are sure that by understanding 2-3 years of question paper, we tend to write answers or learn for our exams in that way. But it's not going to be the same for this CBME batch. So I hope when you people finish your exams wherever you are and try to come back, it's going to be more of practical oriented, skill oriented OSCE stations you'll be having, where you'll have to demonstrate your communication skills, etc. Some of the books I would like to suggest is Dr. Short Textbook of Anesthesia by Dr. Ajay Yadav. It's one of the simplest books for undergraduates. Once you have mastered this, or once you are happy with this and you want to know more about anesthesia, you could go and read Anesthesia and Intensive Care by Morgan and Michelle. Then Miller's Textbook of Anesthesia, which is the gold standard for us, and Barash's Textbook of Clinical Anesthesia by Paul Barash. And benefits of Moksh online sessions are, if you have attended few of their sessions, you would know that top faculty are teaching from the first year itself, and you're going to have live online coaching by global faculty, not only by Indians. I'm sure they have a good faculty pool all over, and the learner will be studying from 10 different countries, I hear. An artificial intelligence based learner management system is being used. There's extensive test analytics and doubt solving support is given. There's unlimited validity for learners. How I would be taking my sessions would be like, I would like to have interactive PowerPoint presentations. My overview and objectives for that day would be projected in the beginning. And then each subtopic, at the end of each subtopic, I would like to pose a small quiz, like just to know how much you have understood in what I have taken. And I would like to drive the basic concepts as it is important for CBME, and when you come for our next exams or exit exams, you should have the basic concept of anesthesia and emergency medicine. I would like to give adequate time for your doubt clearance, and I'm open to you people asking any questions at any point of time. I would like to keep my topics case scenario based discussions. It's vital for us to know why we are learning what through case discussions. And of course, emphasis on how CBME curriculum has told. We have 10 competencies with each competency having few sub-competencies. I would like to cover most of them in my future sessions, and some emergency medicine topics would be covered. Yeah, and coming on to weightage, we have general surgery, orthopedics, anesthesia, and ENT would have 46 questions. So we exactly do not know the uh, weightage for each subject specialty of the surgical field. Anesthesia comes under surgical field in India. Although it's a medical field outside, it comes under surgical field when exams are concerned. Last NEET, I saw that there were 2 questions from anesthesia, and this NEET had 1 question. This NEET had a lot of questions related to general surgery and orthopedics. So each year it keeps varying. Nonetheless, I'm sure you are not all reading for your exam oriented. You need to pick up some basic skills, and anesthesia is quite vital. Yeah,
In which year of MBBS do we come around the subject?
in India, it comes in phase 3, part 1. That is, as soon as they enter their third year, first 6 months, they will be having their anesthesia postings, along with their theory. Yeah.
That is, what is the best way to study anesthesiology during MBBS, ma'am?
Yeah, best way to study is by observing. I hope you all have clinical postings in surgery where you go to the OT, right? You go to the OT and you see only the surgeons. Move around the screen and see what an anesthesiologist does. Okay, that is one of the best way, by observing. Lot of great things have happened by
question.
Yeah. Is there any
No, ma'am, please
specialization?
go ahead.
Yeah.
In
Best way of studying
anesthesia.
anesthesia. Yeah, sure. Yes, yeah, there are books related to anesthesia, and since I'm not sure how it is covered outside, but here in India, there will be 1 or 2 questions in the theory paper also of surgery. It usually comes in surgery specialty, so they will have 1 or 2 questions related to anesthesia and surgery. So they usually read the anesthesia part, which is given in their surgery books itself. We do not recommend any special books to them, but we cover all the competencies, and they would have made some notes in that. So that would be sufficient to clear exams here. But I'm still not sure how it will work for the CBME batch. Yeah, Shruti, I think, yeah, there's one more by
coming up from Bhopal, Kumar, stating that we will study anesthesiology in which year in Ukraine?
Ukraine. Ma'am Mohini, you should take up
this. Specific academics, because every college has different sections from it, and this I think you can this is related to that subject as such, right? These questions you can ask
yes.
to our counselors. We will be getting back to your details, Mr. Gopal. Ask only specific to that stream particularly. Okay, so related to the examinations in Ukraine and other countries, we could ask in the counselor sessions. This is specific to the field, ma'am. Like, I would like to ask a question regarding anesthesia, because we have been hearing about these things, and there are students who happen to ask that what are the if a person has to opt for anesthesia, what are the subjects that relatively that person has to be very perfect into or focus on to, more importantly?
Yes. Yeah, it is basically if you want to get into anesthesia right now in India, it is the 3rd or the 4th option usually students choose. So you need to get a good rank to get into anesthesia in good colleges. And now most of the colleges have anesthesia as their postgraduate programs. It's not a tough one. Mainly, you need to be inclined towards anesthesia. You just can't take it, and it's a 24-hour on call. You should be there sometimes. So it's a hectic, intense work. You'll be posted in ICUs, you'll be posted in pain clinics, you'll be posted in the emergency, OT, pre-op checkups. So only if you have an aptitude for such a hectic job, you need to take it up. And there was one question on, is there any special? Yeah, there are subspecializations in anesthesia. That would be my second talk on anesthesia scope of practice. But since somebody has raised it right now, I would like to tell, yeah, there are specializations in neuroanesthesia, cardiac anesthesia, pediatric anesthesia. Then you have transplant anesthesia coming up, and critical care and ECMO. All these are subspecializations in anesthesia.
Right. Overall, that means they need to have a complete knowledge of the entire subjects to get into the stream of anesthesia.
Yes,
yeah,
definitely.
There's one more. Yeah. So that is that, can an anesthesiologist work independently, or they have to work with a group of doctors? Oh, very good question, Gitansh, I must say so.
Yes. Thank you, Gitansh, for this. Again, it varies on where you are placed, Gitansh. If you are in South India, it's like a group practice. There are a group of anesthetists who have a group of surgeons. They practice in groups. And it is based on how you are going to specialize yourself. Are you going to be only a person who gives anesthesia for surgeries, or are you going to be an intensivist? Intensivists also work in groups, and there are some states in India where there are independent anesthesiologists who practice also.
Ma'am, like, could you
Yes,
throw some lights on exactly what should be the I mean, what should be the scores and what should be this thing? I think there's one question coming up before with that. We'll go with that question first. Overall, we need to be good in all subjects to get it deep into. Yeah, exactly, Mohammed Latif. That
yes,
was
yes.
the question that we had to ask you, right?
Yeah. If you're
So,
planning to get
any
into anesthesia, you should be in the top few ranks. And these top few ranks you can get in only if you have your good base knowledge of your basic sciences and how they can be incorporated into clinical anesthesia, clinical subjects.
okay. I think could you please, ma'am, throw a light that if somebody wants to get into the stream of anesthesiologist only exactly wants to. So what are the specific tips or the things to that particular follow that stream, and like how would it be, the journey would be like exactly?
Yes. Yeah. Once you finish your MBBS and your internship, I hope all of you will start preparing for your entrance exam in India or outside. So in India, it would be the NEET exam what you will be giving, and there's going to be an next exam or the exit exam for all our interns who are of the 2019 batch. So that will include 200 marks question. It will be all case scenario based. It will be higher order thinking skills will be involved. 200 questions with 300 minutes time. So the questions will be framed in such a way that you will have to understand the patient. You'll have to correlate your basic science to the clinical sciences. Based on that, marks will be given. Then once you have got a good rank, then you can choose the college of your choice. And anesthesia, as I told, comes in the first four priorities of most of the students. So the ranking system will be based on how much you have scored, and greater weightage is given to general medicine, OBG subject, then general surgery. So your basic knowledge about these subjects should be really strong.
That do MD needs anesthesia?
Yes, anesthesia is an MD course. Okay. After MBBS, you do a post graduation in anesthesia, and then only you are allowed to practice anesthesia.
In fact, it's a very crucial part because a little here and there in when you happen to do
Yes,
a
yes.
surgery, so we don't know what to ask exactly.
Yeah.
That's what I thought about.
Yeah, yeah, it's okay
Very
because
honest.
anesthesia is something which students are not exposed to that frequently.
Exactly.
So when they
I,
come to postgraduate, they know what is anesthesia.
Right. Ma'am, very importantly, like, a
Yeah.
little here and there into this particular stream, what, I mean, how many what amount of dose has to be given is very crucial in
Yes,
case of
yes. Yeah,
any surgery that we happen to go through.
yeah.
So,
Correct.
anesthesia has to be on the toes while
Yes, yes.
considering every human
Yeah,
being. And I think that we can put a light on more. Yeah, I think you could be the best
yeah.
judge to tell about this.
So people who are seeking for adrenaline kick, there is no other better job than being an anesthesiologist. Okay, so it is like from the time the patient enters the hospital, anytime you can be called, and it is like if you are there, something can happen. So as soon as the patient comes in, a critical patient, I'm telling, the first person to be called is called the anesthesiologist. We need to secure airway. We need to resuscitate him. So that's how important our role is. And as Mohini ma'am just told, your pharmacology and the patient physiology is in your hands when you're anesthetizing the patient. So any dose calculation wrong or administering the wrong drug into the wrong site, you are gone. So it should be like your eyes, ears, everything is open when you're in the OT. How your monitor is, how is the patient behaving. So it's not like anesthesiologists don't have any job. Just give some drugs and they sit and chill. I think you would have seen some jokes about anesthesiologists, surgeons cracking some jokes about us. It's either way is true, but it's not that easier. job. You need to be on your toes always.
Stating that, ma'am, in what ways are MDs different from diplomas in all post graduations? Okay.
Yeah. MDs
Really?
is a master's program for 3 years. Diploma is for 2 years. Okay. In masters, there's emphasis for submission of a thesis. So you'll have to do a research in that subject specialty, which will take around 1 to 1.5 years, and compiling data and writing a thesis will take some more time. So that is one thing which is different in MDs and diplomas. Subject wise, they will be learning the same things. Since the duration of diploma is only two years, the crux of the knowledge what they have to gain, the skills what they have to gain is emphasized more. That is faster milestoning. They will be told to do things little quickly. MDs have a little more relaxed time. The thesis is one extra thing, and usually people who do diplomas will usually follow it up with doing a masters. That is, you can either do a DNB or masters for. If it is masters in India, again they'll have to do it for 3 years. However, Diploma International Board is allowed for 2 years. But only with diploma, you may not be able to get a faculty post in medical colleges. So you'll be doing private practice or be in corporate setups. MD and DNB. MD is again, it is run by state universities. Okay. If it is Karnataka, it is run by Karnataka Rajiv Gandhi University, Maharashtra by their university. But Diplomate in National Board is run by a national body, that is in Delhi. So they'll have a center in Delhi and they'll have sub-centers in all the states, but the exam is single. So they have the same question paper throughout India, and the examiners can be from anywhere. Whereas in MD, you know which university is going to ask your question, and the timing of the exam varies between states. And the examiners who conduct your practical exams would be from your own college. You'll have at least 1 or 2 from your college, unlike DNB, where everyone is a new person. So the weightage for a candidate who has passed DNB is a little higher because it is a little unbiased assessment. But there's no difference in, I'm not sure of the pay scale, but when they start hiring in medical colleges, there's no difference right now by NMC telling that MDs and DNBs are equally are to be considered equal. Usually after diploma, people who do diploma in medical colleges opt for DNB.
That means exposure of MD is more than a diploma, but the knowledge of diploma is more.
No, nothing like that, Mohammed. It all depends that since you have a short time, you have to finish reading the same portion. You'll have to attain the same skills in the short time. The only thing is you're not going to do a lot of research in your time. 2 years is not enough to do enough collect data, then analyze it. So it's not enough. But MDs, they have to do the thesis. And more emphasis for MDs is on paper 4, that is their recent advances. Recent advances is given a lot more weightage for MDs than a diploma. Diploma, they are, since their time is a little less, so recent advances is not covered much in diploma.
That do we get a work-life balance or a hectic life? Really.
Gitansh,
Yeah.
I think, yeah, it's a little philosophical question what you have asked. You can always maintain work-life balance based on how you want to be. Okay, if you want to be a busy practitioner, then 24/7 you'll get calls. There's no going away from this. You could still opt for a life which is 8:30 to 4 or 8:30 to 5, based on how you want to lead your life. But you will still have to have some days which you will have to give 24 hours. Okay, that is till you reach professor level. Maybe at professor level you can still work 8:30 to 5. And definitely I think it is important for everyone to have work-life balance, and it's personal. I mean, how you want to make it balanced.
Question that basically, if you're a work alcoholic, you can choose this
You can
field.
choose this field.
Would
Yes,
be,
definitely. If you are workaholic and more patient oriented. If you want to do a lot of resuscitations, this is definitely the field. How much leave do you get, ma'am? Yeah, since I'm in the medical colleges, I have a fixed leave of 12 plus 10, that is 22 days of leave I can apply, plus government holidays. We have around 12 holidays, so I get around 36 leaves in a year. Yeah, that's it.
That if we have to choose between a MD and a diploma, then on which way we have to go?
Yeah, actually now NMC is also coming up with the new thing that most of the diplomas are being upgraded to MD. In our college, we had 6 MDs and 2 diplomas, and since the past 3 years, the diplomas have been converted to MD. So they are trying to convert all these diplomas to MD. There are very few diploma seats right now present in India. So I would tell better opt for a master's. You have the option of choosing between corporate, option of choosing between private practice, or if you want to be like me in medical colleges. When you do diploma, your scope for practice becomes limited. You have to do private practice. There's more struggle in that.
Yeah, ma'am. I was saying, could you just talk about a case, which they find interesting, that a little here and there, error could cause a big change or big things like that, so that they can exactly understand. Like, I mean, everybody knows about it, but then to, a
Yes.
very
Okay, I can
motivational and
give
a
you
teaching
some
something. Yeah, sure.
examples.
I think we could first proceed with the questions. There are a lot of questions coming up from the students. First, ma'am, what gave you the motivation to select? Yeah, to anesthesiology compared to other branches. Oh, very good question. I think
Yeah,
Rohan.
Rohan. Yeah, thank you for that
This was a
question.
required.
Yeah, thank you, thank you. Yeah, actually, my
Seriously.
first choice was general medicine. Second choice was anesthesia because I thought anesthesia is a little silent. You need not talk too much to the patient. So I did not like too much noisy subjects like pediatrics or OBG. So I chose anesthesia, which was closer to general medicine. But I'm happy that I chose this field. Yeah, that was my main motivation. But I still wanted to be in patient care. I did not want pre-para subjects where I'll be with slides and microscope. I wanted some patient interaction, but not too much of talking. I like to be a little on the sober side. So anesthesia is a little closer to being a little silent side.
True that if we take a DNB rather than MS,
Yes,
we get less exposure to patients if they're less skilled than MS1. I
no,
think in a similar type of question that we happen to. But please, can you? Yeah.
yeah, it is not like that. When you do a master's or a DNB, it depends on which college you are choosing, and based on their patient load, you will be building up your skill set. Okay, it doesn't mean that just because you're doing DNB, your skill set is low. If you're doing your DNB in a setup where there is good patient input, definitely your skill set is good. And there are many centers, even though they are running their masters, the skill set coming out of students from their colleges are not up to the mark because they don't have enough patient load. However, the fee structure for when you're doing your masters is a little higher than when you're doing the DNB program. DNB program has a very small fees. You'll have to pay a very small fees for that. It all depends on which center you're going to be doing your masters. I hope Geetansh it's clear.
Yeah, I think. Okay, Mohammad Atif also, and I think all of the students also would like to hear about some many critical patients and experience about,
Yeah,
ma'am. Like, yeah, discuss.
yeah. Okay, some experience.
Yeah, there's one.
Yeah.
Moment, we will just go over to your question, but I think there's one question come from Arpit Gupta, that what type of work in anesthesiology is done during the MBBS course? Yes,
Yes. Okay.
a
I
very
had some of. Yeah, very
important
nice.
question.
It's really nice to know that undergraduates want to do research, and it's very that is it. The exposure to research at undergraduate level, if it is good, definitely when they come to their postgraduate, it will help them. So they'll have some basic knowledge of their how to go about with research. And definitely colleges would encourage doing small research. It may not be some interventions. It could be something like assessing the patient, doing an airway assessment, and then correlating it with the what the PGs did. So I have done a few with my undergraduates. This is what I give them. It will be basically observational studies where they try to see the patient. That is preoperative assessment or pain scorings, pre-op pain scorings. Then intra-op they cannot do. Intra-op would be done by a postgraduate. Then post-op scorings, wherever they can fit into, they can do research. You can do observational studies. Yeah, there's a lot of scope for research in oncology, especially your nerve blocks. Lot of research is going on into the nerve blocks of oncology patients, pain and palliative care. Definitely there is scope for research.
Okay, ma'am. Can you tell relevantly what is the right now the careers that are opted for anesthesia, other than we are going on that the research work or coming up with some streams that the work is going on that we could throw light on upon currently?
Yeah. Right now there are nerve blocks for CA breast in oncology, then celiac plexus block for pancreas, and right now in our college, yeah, basically those two are some of the high points which I have seen. Nerve blocks, basically it's about nerve blocks. Pain and palliative care in oncology is the main research scope. Yeah.
Okay, fine, ma'am. Okay, fine. I think we can discuss a case that the students would get more try about some critical
Yeah.
patients regardingly, yeah, which they
Oh,
could
yeah. So each patient is
correlate to, yeah.
different. Yes, yes. Yeah. Some interesting case, if you want me to discuss, it would be a patient who is in respiratory. Yeah, we could talk about COVID also. We had really sick patients coming in, and these patients are such that the moment you remove mask from them, they'll desaturate. So whatever 18, 90 they had, within a few seconds, it has dropped to 30. So you have very short window period to intubate these patients, plus taking all your personal precautions. So those are some challenging situations. Then you have intraoperatively surgeons going on operating on CAs, massive blood loss, maintaining their hemodynamics, monitoring their hemodynamics, temperature, then monitoring their drugs. So these could be challenging. Then airway. Sometimes you will have difficult airway, especially these burns patient. 2 days back, we had a burns lady who had come after 6 hours, so with all neck contractures, difficult airways. So what and all you can do. Again, the window period to intubate is very short in such cases. So how you go about with the difficult airways. So those are challenging situations. Identifying pneumothorax, treating them early. So those are some of the things which keep us on our toes. Yeah, Mohammed.
Yeah.
So Mohammed
Could
looks
you
like he's inclined towards taking anesthesia now.
Yeah, well, there's one more question coming up from like the moment the students are knowing more, like they're coming up with other questions. So, ma'am,
Yeah.
has a patient ever woken up in mid-surgery because their metabolism was very fast? Yeah, this usually even we've heard about, many of the cases that
Yes.
it has been happening in that in the middle, yeah. So,
Okay. Woken up means there are two things. Woken up means you cannot get up like that. It will be awareness. It is called awareness during surgery. That is when the anesthetic dose is not set properly, or when, as she's rightly pointed out, that some patients have a higher metabolism. So for them, whatever drug you give, it's not acting on them. So they'll be aware of it, but they can't wake up like a real person waking up. That is, if you have sleeping, you can't wake up physically. It is what's happening in is that they are aware of what's going around because they are relaxed. Muscle relaxant is given, they can't wake up.
that what
What
aspects of anesthesiology excites you the most?
most difficult airway. difficult airway is one thing which excites me the most, and yeah, it keeps us always on our toes. We always need to have some backup plans. Can we do anesthesia together?
Can we do any specialist studies together with any other stream like cardiologists do along with the studies in diabetes? As a question by Mohammad Atif.
No, Mohammed, it is a separate specialty. So anesthesia is something separate. But once you do anesthesia, you can branch out into critical care. You can branch out into ECMO. You can branch out into emergency medicine, as I'm doing right now. But you need to have anesthesia as the base. You could have medicine as your base to branch out into, again, critical care, ECMO, or emergency medicine. You could do medicine as your base and then think about cardiologist. Okay.
Okay, ma'am, there's one question coming up from that they doesn't feel any fail while they pick up during the surgery. Yeah, actually they are in a state of, yeah.
So when I do my next session, you will know what are the components of anesthesia and how we deal with each component, subcomponent in anesthesia. That's the elements of anesthesia. They do not feel pain. Ideally, they should not feel pain. Adequate analgesics will be given. None of you in the crowd have had any surgeries before. Anyone has had any surgery? Yes, Jessica had a surgery. Yeah, Jessica, can you just tell what surgery did you have? Plastic surgery. Okay, Jessica. So I think general anesthesia would have been given, right? As a kid. Okay, okay, Jessica. Okay, fine. Yeah. So it is. It's like as if you go to a dream, sleep, and then come back. Gallbladder stone surgery. Yes. So that is also under general anesthesia. I undergone lumbar puncture 3 times. Sneha Yadav. My God, you have undergone a spinal anesthesia then. So I'm sure all of you would have had different experiences. I myself have undergone 2 spinal anesthesias. One was for my baby, and the other one was for an appendix. So now I know how a patient feels when he is anesthetized. There was one question from Rohan Thomas. How much time will it take? In India, it is 3 years masters and again 3 years for your super specialization. If you want to do anything further like transplant anesthesia or pediatric anesthesia, again they are 3 years. So total would be 6 years. However, outside India, it is quite different. I think the specialization only is 5 years.
So the best opted, what would you suggest to the students who would be wanting to take up at anesthesia as a career? I think, yeah, there is a chance that our patient will not make it out of surgery. How would you handle that? Okay, as an anesthesiologist, there is a chance that your patient will not make it out of a surgery. How will you handle that?
Of course, we would have ASA 3-4 patients coming in who is really critically ill, but you'll have the support from the patient party telling that they want the surgery to be done. We do have such cases, Gopal, and we have to prime them initially only. That is, when you're doing your pre-anesthesia checkup, you'll get a fair idea of the morbidity and mortality of each patient. So that would be explained prior to the surgery, and adequate documentation and consent will be taken for the required procedures. Only after those consents and documentation is done, we go ahead. We need to save our skin too. Tomorrow you should not have litigations against you, right? So one of the ways is documentation, taking adequate consents from the patient or the patient relatives. We do get such cases.
What makes anesthesia different from other streams?
Anesthesia different is we are a bit of everything. We are a bit of neurologist. You need to know your anatomy of the nerves. You need to know how to give nerve blocks. We are a bit of radiologist because now ultrasound is being used for all your nerve blocks. Ultrasound is being used to assess a patient in the casualty emergencies. So we are a bit of a physician because we need to know the physiology of the patient. When you're giving your drugs, you need to be a pharmacologist. Then you need to be a little bit of a pediatrician, because you're going to have a pediatric case, you're going to have a geriatric case, you're going to have a GI case, a neuro case. We are a little bit of everything. So you need to know, it's a little more wider. It's like general medicine. You know everything, you know a little bit of everything in that patient, mainly the emergency part of it, resuscitation part of it. Any one subject
Yeah,
you just
one subject which is core of anesthesia.
core of anesthesia is general medicine. You need to know a little bit of surgery, what the surgeon is doing. So after the surgery, what am I going to expect in terms of his physiology? A little bit of
I
surgery, but
probably
mainly it
think they
is
want to know exactly. Yeah, probably they
anatomy.
are wanting to know the
Yeah.
subject. Yeah.
Anatomy, little bit of airway anatomy, and nerve especially. Nerve anatomy is a must, because you will be giving nerve blocks.
What is
What
there's
is
one person
pediatric?
coming up,
Yeah,
yeah, pediatric
I missed
anesthesia by
that. Yes.
Pratik
What?
Methwani, yeah.
Yeah, Pratik, it is you do 3 years of anesthesia, and then after that, pediatric anesthesia is a super specialization in anesthesia, where you will be dealing with only pediatric cases. So when I do my second session on scope of anesthesia or the role of anesthesia practice, I'll be covering what's the main role of pediatric anesthetist.
Okay, so in the next session, probably you'll be getting to know more about the super specializations opted into this relevant stream and other things into more
Yeah.
details. Yeah,
Yes.
but probably
Next
this is a
class,
complete.
that is the second class from now onwards. Next will be
Yeah,
evolution of anesthesia. After that,
right.
we'll see the scope.
Right. I think this is a complete introduction to this particular specialization that you all have heard about, and getting before into the MBBS. This is a wonderful platform where you're getting a complete idea of what are the relevant streams, what are the options that are available, and what are the core subjects. Every other question that comes to your mind. Okay, one very importantly thing which I have been seeing with the research that when we are going to doctors and going through a surgery, the most important thing we come across is that when they're going to give us an anesthesia, they divert every patient, and the person's very stressed, tensed because of the surgery and everything. So the diversion, and then so that's a very important aspect, I think, that we can really cover too, because it's
Yeah.
like you said that you didn't like interacting much, but I think that was a major part of interaction that
Yes, yes.
very
Yeah.
precious.
How
Yeah.
you allay anxiety, all that in the pre-medication only it starts. How you give them anxiolysis on the day before, how you give them antiemetics. Then when they come on the day, by the time we give our drugs, their anxiety would have come down. That's the property of the drugs what we have, the
Yeah, so
tools
I
what we
probably
have.
think all the relevant questions are asked to the anesthesiologist, that I'll be okay now. All
Yeah,
is
yeah,
okay.
yeah. That scare is there. That scare is still there in few patients. Few patients are okay with it. Yeah, most of them do have this question. Will I wake up? We'll tell you
And
are in
how
safe
about the
hands. For
children?
now, you
How
sleep.
about-
Yeah.
And how about the children, ma'am, when you handle them? How would it be like? Can
Yeah.
you share an experience too?
Yes. Children are very difficult. So we usually would have started an IV cannula in the ward only, and it's very easy when you have a cannula in place. So you can give your drugs as the mother gets the child. We give a small dose of anxiolytic and an anesthetic, and we get them immediately so that they don't cry during transit.
Okay.
Some centers do have pediatric, which looks like where everything is there, stuffed toys are there. So they make it more ambient for the child to come into the OP.
Okay.
So that is one way of doing it. They have scented masks, they have scented fentanyl patches. So just the child will be smelling it and he'll fall asleep on the way. So
And can anesthesia be a fatal?
no. Yeah, anesthesia is not fatal, Mohammed. You don't need to be so scared of anesthesia. It's not fatal. There are very few chances of anything wrong happening. Otherwise, every day, so many number of surgeries happening. Still, the amount of mortality or morbidity that you get to hear is very less. It's not fatal.
So safe branch.
It's a safe branch. Yes, it's a safe branch.
Yeah, there's one more question coming up from Rohan Thomas. Well, that could you share some of the interactions during an operations with your teammates, ma'am, surgeon, nurses?
Yes,
Yeah, I thought
yes, yeah.
most of
Great question, Rohan. So we do work as a team. Okay, jokes apart, you would have had some circulating jokes. Usually, the surgeon puts jokes about anesthetists, and you would have seen anesthesia jokes in surgery colleagues. Yes, it does happen that surgeon has to look upon us before he starts the case. We have to tell you we are ready. Then only he can operate. Okay, so those are some things, and sometimes clashes do occur intra-op or pre-operatively, but it has to be managed. It has to be managed for the patient safety issues. We try to maintain cordial relations, and who knows, your spouse could be a surgeon, but there would be still differences in the OT, right? So you need to maintain relationships, cordial relationships for the betterment of the patient. And over the 3 years of your post-graduation, it will be inculcated how to deal with a strict, how to deal with a non-obliging surgeon. Nurses, of course, yeah. Sometimes it's a little tricky to handle them. You should know how competent your nurse is in the first place, and what responsibilities you can give her and what you can't give her. That you need to be sure at the beginning itself. Yeah, ma'am, what will
yes.
be the next session? Yeah, next session we will go through the evolution of the field in anesthesia. Okay, it's quite a long way we have come through to deliver safe anesthesia at present. We will see some of the great contributions by people from in our field. Okay, we will try to see more about who has contributed and how much they have contributed for anesthesia to be a safe subject right now. That would be evolution of anesthesia or history of anesthesia. That would be the next session, Sanju. Sanu. Yeah.
Ma'am, do BDS doctors
No,
also need coaches? No,
no, they don't have anything
nothing.
specially for no. As they are doing their BDS, anesthesia is taught to them then and there. So they don't have to do separately anesthesia. It's a part of their curriculum, BDS curriculum. N2 nitrous oxide, uh, they can administer. They can administer whatever in their facility. They should have had the license for that to use nitrous oxide and oxygen. You just can't use nitrous oxide. They should have used nitrous oxide oxygen mixture. They should have been trained in that, and only then the license will be given to that dental surgeon. Local anesthesia, definitely they can administer, but when they are using nitrous oxide with oxygen, they should have been trained in their curriculum, and then only they'll be given license to use that. Otherwise, they would have to call some anesthetist when they are using nitrous oxide for their kids.
So I think they must have really got a lot of information on the relevant streams and what are the drugs. It's a great experience and a very careful. You have to be, I think, all the time alert with the patients and with these things. Ma'am, do you have any such experience to share with the students, particularly that was critical or something like that? Only need the okay. This is a very important again question. To are in a surgery only required in the beginning of the surgery,
No,
or
no, throughout the surgery, beginning, throughout, and even in the post-op. Okay.
yeah, or during the whole surgery? Yeah, sure. I think at the whole of the surgery. And there's one more question coming up from Yogini Deshpande, stating that have there been cases when an overdose occurred, and how was it handled?
Usually they are careful. The 3 years training would teach them in anesthesia, everything is per kg body weight. So everything is learnt as per kg body weight, and as soon as they enter the case, they'll have to stick it up on the anesthesia machine. So for this case, I'm going to give so much. If in case overdose occurs, then there are ways to reverse it. It is not that it cannot be reversed. There are ways to reverse it, but the thing is you have to have recognized that you have given an overdose. The problem occurs when you have not recognized that you have given an overdose and you have extubated the patient earlier and not monitored in the post-op. So those are the cases where you get stuck. But if you are careful in what you are loading, you would have seen some anesthetists with this big lens with them. Okay, so that is to see what the ampules are, to read what ampules, what's the expiry date, how much they are loading. That's taught in their training, that you have to be doubly checking whatever you're giving. And how the patient is responding, you will know. You'll know how, when you give overdose, the way they respond in their hemodynamics, that is their heart rate, BP changes, you will know that something wrong you have done. That's when you go back and check your ampule, check your syringe, if you have given an overdose, and most of them would have had reversals. So how you reverse them is important.
So there's one more question I'm coming up from Gopal Kumar. Is it dangerous for a patient whose ECG is not normal and he or she is undergoing anesthesia before surgery? If yes, then why?
Yes, yeah, Gopal, wonderful question. If ECG is not normal, then something is abnormal. Is it the rate, rhythm, or is he having some ischemia changes? Based on that, we decide whether it's an urgent surgery, semi-urgent surgery, or whether the surgery can wait. So if it's an arrhythmia, you can treat them based on whether it's atrial or ventricular, the cause for arrhythmia. If it's an electrolyte imbalance, treat it up and take. But however, if it's an emergent surgery, if you have to take up the surgery, even with ECG abnormalities, you need to take risk consents. Risk consents and what could go wrong. Okay, we have patients who come with intense peritonitis with obstructions with all ECG changes, elderly man. You cannot deny them surgery just because their ECG is abnormal. Take due risk consents and monitor them for all these electrolyte abnormalities, ECG changes further worsening, and accordingly we have drugs to treat them. If the BP is low, we have inotropes to give. So it basically depends on whether it's a urgent, semi-urgent, or an elective surgery.
So totally, even cardio surgeries also can be monitored through the urgencies level only, right?
Yes,
Particularly.
yes.
Yeah. So, ma'am, there's one more question coming up from Mohammad Atif, that do anesthesiologists are needed in a laser surgery too?
Yeah, it depends on what laser surgery the surgeon is planning. For eye surgeries, definitely they don't call us. But if it is urological laser surgeries, they do require a backup of anesthesiologist. If it is ENT laser surgeries, of course, backup of anesthesia is required. Except for eye, we are required. Eye surgeries, they manage themselves. ENT and urological procedures, they do require our help.
Stone kidney also probably.
Yes.
I think, ma'am, even for the plastic surgeries and all, we do require, right? For the plastic
Yes,
surgeries.
yes, yeah, correct.
Right. So major surgeries which are to be handled with critical care needs to be having an anesthesiologist and exactly the dose and the things to be counted about.
Yes, correct.
Ma'am, one question from my end also, that if there is a cardio patient in a very acute condition, then then how do you, I mean, what it is exactly about, and how do you, I mean, the time is very less.
Yeah, it depends. Sometimes they would have to undergo a cardiac surgery before they come into whatever surgery they were posted for. Like we do have elderly people coming for urological procedures, like prostate enlargement, but they would have had some issues with their heart. So usually they undergo stenting or open heart surgeries, and then they do the procedure of TURP. Again, based on the severity, which is the priority more, whether it's the prostate priority or the cardiac. So based on that, the call is taken up by, this is a combined decision. Again, here you need a team of cardiologists, then you need cardiothoracic surgeon, urologist, anesthesiologist. So it's a teamwork. They decide what is best for the patient at that time.
Okay. So a complete team has to be taken into account, and
Yes.
then they
Yeah.
decide
Yeah.
about the patient,
Yeah.
the case of the patient rather. Right.
Yes.
Okay, ma'am. In tissue grafting. Okay.
Yeah.
Yeah.
Yes, we are required. Tissue grafts are plastic surgery. Of course, we are required. Plastic surgery is a very vast subject, Pratik.
Subject.
It is basically a surgical field. Okay, again, it is like a master's degree. First, they have to do their MS in general surgery, and then again, super specialization in plastic surgery.
Do doses change if a person is diabetic along with the heart ailments? Yeah,
Yes,
this is a
yes,
very important question.
definitely. Definitely, dose will change based on their how much, if there is there any water retention, or how are their nerve status in diabetes. Based on that, based on their BMI, doses do change. That's why you need to know the physiology of that patient to adjust your doses.
Right.
Doctors use plastic glasses. No,
Plastic
no, Pratik.
surgery. No, never. Pratik.
No,
No,
no, Pratik.
it's banned completely. You can, the doctors also cannot use, right?
Yeah.
Yeah. So there'll be a different topic where you can have in the LMS also. You can go through in the later what is a plastic surgery and all that.
Yes.
Yeah, that's a different specialization altogether.
Do you ever
Did
feel
you think the work is monotonous? Is a question asked by Rohan Thomas.
No, Rohan, each case is different and each case will come with its own challenges. So it's not monotonous. Don't worry, it's not going to be monotonous. Once it gets monotonous, then you can change your field to critical care or emergency medicine, as I jumped to now, but it's not monotonous. Each patient is different. They come with their own set of problems, and each has to be dealt differently. So there's nothing monotonous.